Thank you very much, Shah. So greetings, everyone, and good evening, Manila. Happy to be here with you, all the e-health information experts in Asia region. I'm so happy and grateful to Alvin for organizing this. And we're happy to be spreading the word about the CRVS Strategic Implementation Plan. But first of all, of course, every single one of you knows what CRVS is, but just as a reminder, and then I will take you to the WHO mortality database, what WHO has been doing for the past 70 years in keeping this very valuable database, and what are the score findings, and what is the reaction of WHO in terms of strengthening more efforts towards the improvement of CRVS systems, and then what happened during the COVID-19 when it comes to CRVS systems. Very, fast and hopefully not too boring. So let's go. So what is CRVS? CRVS is Civil Registration and Vital Statistics. But when you consider civil registration by itself, civil registration is the process where major vital events, they call them vital because they occur in people's lives. So major vital events that are occurring in a population are officially recorded. And the official definition of this is the continuous, permanent, compulsory, and universal recording of the occurrence and the characteristics. The characteristics is a very important part when it comes to the statistics of vital events in a population in accordance with the legal requirements of the country. And what are these events? There are many of them. There are live birth, death, fetal death, marriages, registered partnerships where they exist, separation, divorce, legal dissolution of registered partnership, annulment of marriage, adoption, legitimation, and recognition. But we in WHO are basically interested in live birth, and of course stillbirth as well, because that's part of death, death in general, and fetal death, okay? So these are what we are focusing on for very important public health decisions, and of course causes of death. Okay, so what is the relevance of this birth, death, and cause of death information? It has three major, I'm not saying this is all, no, but three major, and there's so much more. Legal, statistical, and epidemiological, public health as well. So legal, we know, in order to certify the occurrence of the fact of birth and death, which means certifying the age of the person, basically, and the ensuing rights that come with the age. And then to define whether this death was natural or not natural, and of course the consequences of that when it comes to forensic medicine and legal medicine and the action to be taken by courts accordingly. And of course, most importantly, legal identity, because that is also with ensuing rights and voting rights and so on. Statistical, we all know about the demographic part of the population, the composition of the population when it comes to sex, age, ethnic groups, where these populations reside, the socioeconomic data related to this population, and all the very important vital statistics that come out from the different correlations between all these characteristics. And of course, for WHO, it's basically the epidemiology and public health aspects coming out from the causes of death of all groups, whether they are infants, neonatal, under 5, mothers, men, women, all the age-specific death rates and the cause of specific death rates. Very important for all the public health decisions, and everybody in the world now has become an expert in public health and after the pandemic. So the needs and uses of mortality statistics. Very important just to stress that the mortality by age, sex, and cause of death is the foundation of public health. And we need that to compare within countries and across countries. And we need to identify the health inequalities and the establishment of public health priorities and the monitoring of trends and evaluation of the impact and effectiveness of the public health programs. So just a small example of which, of course, all of you are very much aware, is the lung cancer, you call it epidemic, that we had a few years back in the 1980s and 1990s because of the smoking. And then the lung cancer started increasing humongously until countries started to take actions for smoking. And then we noticed that death started to come down. And these are like USA, Japan, France, Sweden, and Australia. You notice around the 80s and the 90s that lung cancer peaked and then started falling. So this is one of the uses of mortality statistics, and that is regarding the interventions, effective public health interventions. Okay. The screen has just froze. Okay. So WHO has been compiling mortality database, compiling mortality information for the past 70 years, ever since 1950. And so we have 70 years of cause of death statistics, and it is available to the researchers and publics on our website. Of course, it wasn't always in ICD-10. When we started compiling it, it was already in the ICD-7. And of course, you know that this data existed since 1900s in ICD-1, but WHO was not created at that time. So as soon as WHO was created in 1948, we took this on board, and we've compiled this data first in ICD-7, then ICD-8, ICD-9, and ICD-10. And this year, we started to get one country in ICD-11. What happened from the analysis of this information? Everybody knows the epidemiologic transition, or what we call the health transition, or the demographic transition, is that the increase in the mortality from non-communicable diseases, and that happened in almost every country of the world, and the decrease in communicable diseases, and then the flattening out of the injuries. So the injuries are basically have flattened out because of the prevention measures, but the NCDs are still going up. Of course, now it's a little bit different after the COVID pandemic, and we will see a peak. We will see a peak in 2020 and 2021 in the communicable diseases because of the COVID. So they're just a reminder that the communicable diseases are not really over. They are dominating very much, even though we think they're going away. So in WHO, we have what we call the SCORE assessments. These SCORE assessments were started to be conducted 3 years ago, and the analysis was just completed a few months ago, and the WHO kind of released the findings about a month ago. So what is SCORE? SCORE stands for Survey, Count, Optimize, Review, and Enable. And these are basically the components of health information systems. So for any country to be able to have information on health, they have to conduct surveys, they have to have a functional CRVS system, they need functioning health service data, or what we call routine health information system from health services. And then they should be able to analyze the information they've collected, and this is the R, means review, progress, performance, and they should be enabled to use this data for policy and action. So the acronym of SCORE came up. And which countries participated in this SCORE exercise? Basically all countries in Africa, in Afro, 83% from AMRO countries, which is North America and South America, 91% of AMRO countries, only 1/4 of Europe, 100% of CIARO, all of the CIARO countries, and only 1/3 of WEPRO countries. And by economic groups, this is what it looks like. So basically what the SCORE did is it calculated a score, like an overall index for each one of the major health information system components. So globally, from the 133 countries investigated, the surveys out of 4 came out as 3.5. And the CRVS system was the weakest with 2.9. The health services was 3.1, the analytical capacity 3.7, and the use of statistics for action was 3. So this is the overall scores for each of the components of the health information systems. The main features was that for the surveys, we found out 68% of the countries had a good capacity for public health threat surveillance, the surveys. For only 40% of the world deaths remain unregistered. For the health services, 50% of countries have limited or less capacity for systematic monitoring quality of care. 60% of countries have good capacity to review progress, and 59% have a good capacity to use data to drive policy and planning. So there was an overall C, what they call the overall like functioning of their CRVS systems. So when they did the average for Africa, it was around 1.6, the lowest, and the highest was in Europe with 4.6. And that maximum score here for the C was 5. And the global average was 2.9. Okay, so when it comes to CRVS systems, if we dig deeper, like what they call a deeper dive into the statistics, we found that around 44% of the countries studied, the 133 countries, had a nascent, which is the pink, or limited capacity to count birth, death, and causes of death. So this is basically a reflection of the CRVS systems in these countries. And then when it came to the calculation of birth and death registration, of the overall global was 72% for birth and 62% for death, and Africa being the lowest. But we need to look at these statistics with a pinch of salt, and I will tell you why in a second. The actual statistics are a little bit different than that, because we only studied 133 countries. We have something which is really beautiful, which is an online portal by country. So I extracted this for the Philippines, and this is what it looks for the Philippines. The surveys were all in the green, and see that the legend is here, with the pinks being the worst and the blues and the greens being the better parts. So when it comes to health service data, they're still in the yellow, the Philippines, but the other ones are in the green, mostly in the green, have not really gone into the blues yet, but so this is how it looks for the Philippines. And this data is available online for all countries that were studied, 133 countries. I thought I would just show you this from the Enable, which is using the data for policy and planning. And of course, Africa, as usual, came out with 2.6, but Southeast Asia was 3.2, and very close to Europe and the Western Pacific with 3.6. But the most important finding for your group, which is the digitization part, was that for these countries, there was a national monitoring and evaluation plan in 74% of the cases, and of these, 21% met at least the standards of the M&E plan. And when it came to the national digital and e-health strategy, 62% of the 133 countries did have a national digital e-health strategy. And of these 21%, the strategy met at least 85% of the standards required for a digital e-health strategy. And the score recommendations at the end was that, firstly, to strengthen the CRVS and the death certification systems, improve health disaggregation to identify the gaps, especially among underprivileged populations, in order to address the inequalities, and very clearly shown by the COVID pandemic. And then guide investments across all the major programs to strengthen the general health data systems, not only specific programs, but all programs, they need to strengthen the data systems. And then we need to strengthen the data governance regulations to improve data access and sharing and to translate data into policies. So WHO, what have we done? We've been doing a great deal in CRVS strengthening, and you will notice that Mark Landry and Rakesh in CRO have been doing excellent work when it comes to CRVS strengthening, and EMRO the same, and in PAHO the same, Europe the same. And through, of course, the challenge is much bigger in Africa, and it's also big in the CRO region, but we've been doing a lot of work. But in order to put like the cherry on the cake, WHO has developed a CRVS strategic implementation plan to cover the period between 2021 2025. And the aim of this strategy is really focused. We're not going to do everything like we used to do before. No, we're not an economic commission. We are the World Health Organization. So we are going to focus on things that we can do and things that we can influence. And so the aim of the strategy is to empower member states to more effectively mobilize their health sector to lead or contribute to CRVS system strengthening efforts in order to ensure maximum benefit from routine data systems for policy and development. What does that mean? But let me take you first to just out of the oven statistics. We are developing a global birth and death report, and this information is like really still in. It is the most up-to-date available globally, and it's, of course, it's still out of the oven. So maybe a little bit in Africa we can get more information. So, but this is what it looks like. Birth registration. Everything green on this map is over 90%. Everything red is under 50%. And yellow is the one between 75 and 90, and the orange is between 50 and 75%. Because I know everybody's working from their laptops, so the legend may not be very visible. But it seems, it looks like we're almost there. I'm sure we can get more information from Africa, and that's what we will complete this information, because it does exist. Most of them are lower than 50%, but the information may be there, so this information will be completed. Then let us look at the figures. The figures are really surprising. The global birth registration is 62%. It's a little bit lower than the death registration. And why? Because we're taking registration of birth at birth, not within the 5 years, like sometimes the definition. If we take it within the first 5 years, which include those who become registered, at school entry, it goes up to 73%, which is equal to the figure produced by UNICEF. But if you only consider those done or registered at birth, it's 62%. And also to note, a very important fact is that 88 countries, which are almost half the countries of the world, have 100% completeness of birth registration, or quasi 100%, which is also not bad news, it's good news. The Africa region, however, goes down to 20%, but I'm sure when we get the rest of those countries, maybe it will go up a little bit. Okay, this is what it looks like when it comes to death registration. Very similar picture, very similar pattern. The greens are the over 90%, with the yellows from 75 to 90. And the reds are the below 50s. But this is the table that will really surprise you, because the death registration is around 72%, with males only slightly higher than females. And why? Because of India. The largest difference between male and female completeness was in Southeast Asia region, largely due to India. Male completeness was 80%, whereas female was 67%. This is when it comes to death. But of course, a lot of disparities exist between the regions, as you see. It's a different picture. And when you go and you drill deeper into the countries of each region, the picture will look different from one country to the other. Okay, so let's go now into the strategy. So what are we doing? What are we focusing on in WHO? We're focusing on 4 main areas of work, or what we call strategic objectives. The first strategic objective is what Alvin and the company are helping us with today, which is to strengthen the coordination between national stakeholders on the ground and international stakeholders working in the CRVS arena at the global level. So WHO will use its convening function to bring together stakeholders at local level, the Ministry of Interior, with the Ministry of Justice, with the Ministry of Health, with the statistics offices, everybody concerned in order to get this system working properly. And for you, of course, your group, as mentioned in the title of this seminar, digitization is important. So we need to link all these sectors together electronically in order to get these systems working. So this is the first strategic objective, which is about coordination, streamlining, harmonization, interoperability, on all the e-health and the digital health acronyms you would use. The second, which is the heart of this strategy, is to strengthen the notification capacity of the Ministry of Health. And this is also very much dependent on digitization and electronic systems. And so we have the easy part, which is strengthening the notification capacity from the health facilities, which is the relatively easy part. And then the more complex part, which is notification from the community. But this can also be done through the health sector, not only through other things, it could be done through the health sector. So what we're asking here, the key strategies is direct electronic notification from the health facilities. And now it's easy because we have the mobile phone technology and all the things that you know better than me about, from the health facilities directly into the Ministry of Health database and simultaneously into the Civil Registration Authority. So when somebody comes after a few years, maybe at school entry, and he wants to register their child for birth or register the death for inheritance, the notification is already there. They don't have to go to court to register the event. They don't have to get the witnesses to determine the dates where this person died, or whether this person died before this person, and all the hassle that goes. The Ministry of Health will have all this information already in their database on a daily basis. So it's timely. Had we had this before the COVID pandemic, the situation would have been much better. Maybe we would have prevented many of these deaths because we would have had early information, timely information. So this is the key component of this strategy. Timely, electronic, direct notification from health facilities and communities into the Ministry of Health database and the civil registration and perhaps the statistics office all at the same time. Okay, the third one is obvious to all of us, but it doesn't ever happen fully, which is building the capacity of the health sector to analyze and use mortality and cause of death data for policy purposes. Show them how to use ANACODE and Anaconda to analyze causes of death and analyze mortality and excess mortality and all this, which are now the developing, we've been around for a long time, but also developing. And also show them how to use verbal autopsy and the interpretation of verbal autopsy and so on for death in the community. And as O4 is what we should be doing more is improve the reporting, production, and dissemination of vital statistics, including causes of death. And the reason many of the countries that you saw in Africa did not have figures for birth and death registration was that they did not publish them. Not because they're not there, no, because you would really have to go to the Ministry of Health and ask them what are they, but they are there. So we need to improve this component very much so that we know what to do. We need to find out where to act and how to act. So this SO4 aims to assist countries in improving the compilation, validation, reporting of birth and death data on a regular basis using standard formats for further dissemination and use. And we have prioritized some countries for action, but these are a flexible number of countries, and any country that wants to be prioritized, we are most welcome to help. So this is probably like the negative image of what what you've seen before. So these are the countries which showed up in kind of yellow and and red. Okay, so what happened for CRVS systems during the COVID-19 pandemic? Very interesting indeed. First, we noticed that even though some countries did report mortality statistics to WHO on an annual basis, they failed to do that on a weekly basis in a timely manner. Why? Because they did not have electronic systems. So only countries which had electronic systems for reporting death were able to report weekly information to WHO and the other organizations. And this was like a major finding, probably that we failed to recognize before and that we need to address now. So all of you in your countries, we have to digitize the mortality systems ASAP. This is like a key priority for us. What else was found? We found that the COVID-19 pandemic has impacted the ability, of course, of governments to maintain most government services and routine functions, and that included the CRVS systems. So the UN Legal Identity Task Force developed guidance in March 2020 for on actions that could be taken by countries to maintain the CRVS system functional during the pandemic, and these guidelines are available online. And then there was a survey conducted between March and April by UNSD 2020 also to investigate the impact of the pandemic on the CRVS systems. And the 61 countries responded to the survey. Half of them were in Africa. And the findings indicated that there was some impact on the CRVS system operations. 6 countries, there was complete closure. And then most of the countries, it was partial closures, and some of them was like hybrid in between. And the innovative approaches that were observed in many countries was that despite the lockdowns and the reduction in services, the health sector remained a very important source on birth and death. And that although 2/3 of the survey respondent countries did not routinely submit vital statistics to WHO, they did report COVID-19 death to the global monitoring organizations. Yeah, that means they do have the potential, but they need a push. So this indicates that there's a functioning mechanism for reporting death in these settings, and that these experiences and the COVID pandemic could be a good opportunity for us to strengthen the overall national vital statistics operation beyond the current crisis. And the potential positive outcomes of the pandemic was that there is now increased attention to mortality statistics. There is enhanced data management through digitization, again, very important, and improved intersectoral cooperation for vital event notification, and of course, improved community awareness of CRVS. Everybody knows now, because it's on CNN, on BBC, on all the news every day, the number of deaths, excess mortality, everybody now is more aware of CRVS systems. And it's most likely that these positive outcomes will catalyze the development of national CRVS systems to provide essential public health services and meet the data requirements for planning, monitoring, and human development. Okay, so what is the way forward from this? Is that our aim is to have timely, reliable data on birth, death, and causes of death. Why? For sound public health policy and decision making. So we are going to continue to strengthen our partnerships across the globe with all the international and national agencies to operationalize the CRVS strategic plan and focus on the notification capacity of the Ministry of Health. And the key main strategy is direct electronic notification of vital events, whether it is through the telephone lines, through internet, through whatever, but it is doable. To minister, and even in the areas where there is no electricity, it's still doable through the panels, the solar panels, and the telephone lines. We are developing 2 main global reports being finalized, and the results that I showed you now is one from the status of birth, death, and causes of death, and the second one is on the status of CRVS systems, and the data for the countries will be individualized so that each country can see how they were placed, and this will be the baseline for the future reporting and future improvement. We have WHO expert and advisory groups to improve standards, measurements, and capacity. And I thank you very much for your attention. Over to you, Cha.
Thank you, Dr. Adsa. So to all our participants, we're now open to questions. You can use the chat box, or if you would like to use your microphones, the microphones are enabled now. Please use the raise hand button so we can call your name.
Hello, can you hear me, Doctor?
Yes,
Dr.
hi,
Bunchai.
how are you?
Good,
So
good.
good
Hi.
to see you again.
Yes, thank you very much for your presentation. It's very informative. I have I have a question. Which department of the WHO headquarters are working on the SCORE survey and also with the CRVS implementation plan? Over.
Yeah, it's the department where I am working. It is led by Dr. Samira Asma. It's called the DDI. They are responsible for the data, all the data of WHO. Department of Data and Analytics, and that's where and then this is the big division, and the department where I'm working, where it has the SCORE and the CRVS, is called SCH, surveys, CRVS, and health service data, and that is led by Dr. Somnath Chatterjee.
Thank you. I searched the internet while you are speaking and try to find the website that we can search for the.
Sure, I will share it with the chat so she can share them with everyone.
Yeah, I saw only the SCORE to WHO INT, but it's only tools, no statistic. Is it the same website? I can. Post,
yes, you're supposed to find the global report there as well as the country portal. Maybe I will find them in a short while and send them over to chat to share with everyone. Oh, here it is. No. Yes. Okay, this is the one that you sent to me. This is the tools, but there's another one where it has the online portal. It is within the our statistics website, the DDI. I'll find it and I will send it to you.
So this website only have the tools and a lot of resources. I recommend everyone who are interested in this go to this. Is very easy to use. I found that a lot of tools on the birth date and cause of death. Over. Thank you.
Thank you, Bonchai. Okay, so now I have seen a few questions, maybe on ICD 11. Or how are we going to do this, Chai? You're going to collect the questions, or do you want me to just go ahead and answer them?
Yes, we can proceed with the first question from Professor Teng. So it reads, can you provide more information about progress with ICD-11 and CRVS?
Okay, so ICD-11 is progressing very well, and we are now developing several tools to make integrated systems, meaning that for countries that are still new in their mortality statistics part and they want to start on ICD-11, and we're doing it for ICD-10 as well, is we have an integrated package where a health facility will go in, input the microdata of birth and death individually, and then the system automatically will tabulate the causes of death by age and sex. It will do the analysis like the Anaconda. So we will link Anaconda, code edits, the data entry, the death notification form, code edit, Anaconda, the dashboards, everything into an integrated, and this is again digitization, and we need your help also in this. And when it comes to ICD-11, we will integrate the iris also into that same program so that the selection of underlying cause of death is automatic, at least 80%. And we're developing similar tools for ICD-11. So we will have an electronic platform for data entry and the selection using the coding tool and the APIs and the container Docker versions, so that for some countries, they need that for confidentiality of cause of death information. And we will link it also with another software that we're developing to select the underlying cause of death using ICD-11 codes. And then the dashboards and the analysis, the ANA code, we have an ANA code 3, which analyzes the causes of death from causes of death that are coded in ICD-11 codes as well, and the dashboards and so on. So we're having these integrated platforms that should make life easier for countries, but the ICD-11 is coming out quite beautifully.
Thank you, Dr. Adsa. Our next question is from Dr. Kalpana. Is ICD-11 ready for mortality coding? And which one is better for mortality coding, ICD-10 or 11?
Of course, ICD-11, of course. First, because it's updated. It has, we have stopped now updating ICD-10 for some time. The latest version was the 2000, I think it was, the print was the 2016, and then we updated again in 2018, but that was, I think, the browser, the online browser. But since then, it's not, had not been updated. ICD-11 has many more diseases and many more features. And then, of course, those who know they have the extension codes, they can do marvels with extension codes. It's basically an undiscovered digital platform that countries can use them in a very versatile manner. So maybe like Dr. Bonshai in Thailand will use the ICD-11 to code because they have a specific health issues that they want to bring up on the surface. So he will ask his team to make sure that they use the extension codes more extensively in order to find out, for example, the traffic, the bicycle accidents, how they are happening and where they're happening. Whereas in another country, they want to use the extension codes in a different way to project another, in terms of cancers. It's even now, you don't have to use the ICD-0 for the oncology, because you can use ICD-11 as a one platform for everything. And it is really beautiful. And when you use the ICD-11, if you find something that is not there and that you need us to add, you just have to go on the platform and put in your recommendations. And we have a whole team of the WHOFIC network that will address all these questions and will add them on there. And it's all electronic, so it's overnight, it will be reflected on the system.
Thank you, Dr. Adsa. We have another question. This is from Dr. Ben. So what kind of support or potential support can be provided to countries by the WHO to strengthen the CRVS, especially in the area of digitization of the CRVS?
Excellent. We will provide you with all the support that you need in order to digitize your CRVS systems. We have Mark Landry in Seattle. We have Jun Gao in WebPro. And of course, we have us in WHO Geneva. And we have with us many partners that will help. And I do have some funding for prioritizing the digitization of CRVS systems. So just send your requests to your country offices or to Mark Landry or Jun Gao, and we will be there to help you. It's not one of those very difficult things that they are easy. We just need the will of the country, the will and the commitment of the country. We are here to support you.
All right, thank you, Dr. Adsa. The next question is from Dr. Julius. So what should the health-related academic sector focus on in terms of CRVS or digitization in general, either short-term or long-term interventions?
Okay, the health-related academic sector, I think, should focus more. Then we have the faculties of medicine, which should focus on teaching the physicians how to certify death, because they learn medicine, but they don't learn the death certification part. They don't understand the concept of underlying cause of death. This is the most important part. Definitely, this is the most important part, because no matter what digital systems you put in place and the information input is wrong, or it's not descriptive or specific enough, then we have garbage in, garbage out, as you all know. So for us, putting the curriculum in the adding death certification and ICD coding as part of the curriculum of medical education is the most important part of this. When it comes to the digitization part, I think it's just like normal digital electronic work. It's nothing specific to CRVS systems, except the validation, of course. The validation of the CRVS systems are very specific to mortality. So those of you who are working in mortality systems, they know that, for example, you have to limit the list of diseases, like the obstetric, the O codes, they cannot be assigned to males. The diseases of the genitourinary system, some of them cannot be assigned to females. Some diseases are diseases of the neonatal period. And so this part has to be learned. This has to be, and we do have the knowledge about that, how to put the validation of the causes of death into the systems to reduce errors, to reduce data entry errors, to flag them out. Over to you, Shah.
Yes, thank you, Dr. Adsa. We have another question from Professor Deng. So, what is your current experience with digital notification of deaths from outside of health facilities? For example, WRT, to completeness or duplication of vital statistics?
Very good question. Very good question. I need your help in that, because we do have duplication when it comes to data entry sometimes. And the only thing that I remember in Djibouti, we had this problem, and the Civil Registration Authority always used the name of the mother to make sure that this is not a duplicate entry. So they compared the names of the children. Sometimes even the names of the children were entered in different ways of entering a name. But when they looked very close and the date of birth looked very close, they always compared the name of the mother to avoid duplication. It has worked in many settings using something else, because even if you have two children born with the same name of child, same name of father, they will never have the same name of mother. So we can put some validation, but usually these validations have to be in some settings done manually. But it's until we find a way that they are done electronically.
Thank you, Dr. Adsa. We have our next question from Dr. Nirmal. So, do you have standard guidelines for CRVS software? And does the WHO recommend any open source software?
And WHO is so far recommending DHIS2, and we, in collaboration with the University of Oslo, we have developed and also with UNICEF, we have the platform for birth notification. We have the DHIS2 small for death notification. We have also now developing in Siaro for Bangladesh, another DHIS2 platform for death certification in ICD-11. So, so these are the open source platforms that we are recommending, but that doesn't mean that countries sometimes want to use something else. I mean, it's up to them depending on what they have, but we find them easy and they're already available.
Thank you, Dr. Adsa. So far, there are no new questions, but there's a request from Dr. Vladimir. So, Dr. Vladimir will be sharing the links and the resources of this webinar once they're available. Are there any more questions from our participants? All right. There's another question from Dr. Vladimir. So,
On
what's
open
WHO's
CRVS?
position? Yes.
Yeah, actually, basically, we have no position so far. If a country wants to go ahead and use it, it is always the position is usually the country's position. I think it's something an easy way to have countries have a ready platform to use, but I don't know why sometimes countries prefer to have their own systems. Usually they're a little bit apprehensive because of the confidentiality of the data, and they're not willing to use the open CRVS. But for us, it's we are completely neutral when it comes to that. We leave it up to the countries.
There's another question from Professor Ding. So, with digitization and audio technologies like SoundX, is it possible to improve accuracy in recognizing similar sounding names in different cultures? Your thoughts on that, Doctor?
Wow, this is, I mean, this is new to me. I would be learning this from you, but this is, I think this is really something great. Maybe we can have a session on this, and you can show us how this could be used, and we combine efforts. And if this works well, maybe we recommend it to the countries to make life easy for everyone. But I'm not sure. I have no idea what that is, but it's that should be very interesting.
All right. Any more questions?
Hello, I have some comments and questions. To my experience on working with the CRVS, WHO health sector is part of the bigger system of the civil registration. And the big hurdle for every country is that to collaborate between stakeholders like the national statistics, the Ministry of Internal Affairs, or whatever country have that work responsible for the civil registration. So my question to Dr. Azar is that how we as the WHO have a kind of the support for the country to, I mean, working on this stimulate or advocate for this collaboration. To my experience, we have a very little power on working. I mean, to influence the agency that are responsible for the civil registration. We only have the power of the support of the birth and death, the vital event that occur in our health facilities. Over to you.
Yeah, very important question, Dr. Bunshai. This is really what, I've done so many comprehensive assessments in WHO for the past 10 years. And of course, what we use the convening power of WHO to get all these stakeholders together. And when the Ministry of Interior does come to the meetings, and they usually do come because our country offices are quite strong. They are quite strong. I was really surprised how we have a very good WHO, excellent leverage on the ground. So the Ministry of Interior do come, and they do come in large numbers. But the problem is the power, the show of power. It's usually the Ministry of Health are a little bit not so showing power in the meetings, and the statistical offices are even worse when it comes to this, like show of power in meetings. But in my point of view, this will disappear. This will disappear if we empower the health sector. And how do we empower the health sector? If they have as many or as much information as the Ministry of Interior. What happens now is the Ministry of Interior holds all the information. And where does this information come from? It comes from the health sector. So the health sector notifies the Civil Registration Authority through usually paper notifications in systems where we need to do more. It's usually the case. And they don't even keep a record in the health sector of all these events that take place on this in their institutions. So in some countries, the birth registration is 10%, whereas the institutional deliveries are about 60%. So this birth took place in health institutions that are regulated by the Ministry of Health, yet they don't keep information on these 60%. So the Ministry of Health is powerless. Then they go to the Civil Registration Authority and they try to get that information from them. So if we empower the Ministry of Health, they will basically have more information. They will have the 60%, and the Civil Registration Authority will only have 10% of that information. So they will cooperate. They will be forced to cooperate because they need this information as well. Everybody needs this information. So they will find that, okay, let's do business together. You give me all these notifications, I give you the overall registration coverages, and we can work together in harmony. This is the only way that it works, I think. But it's a very common problem. I agree completely.
Thank you, Dr. Adsa. There's another question from Dr. Nirmal. So, could you please provide good examples of digitalization when it comes to birth notification from health facilities and that notification being rightly used by birth registration and the certifying body?
Of course, I will give you examples, many examples from the EMRO region, where many countries have digitized the Civil Registration Authority from the hospitals. So when there are two mechanisms. One mechanism whereby after the physician delivers birth, he will go into the system, and basically just the nurse will enter all the information on the ID of the mother, the ID of the father, the name of the child, everything, and the physician will check the information and will put his electronic signature on it, and automatically it goes into the Civil Registration Authority. That person, then the father of the child, will go next day to the Civil Registration Authority to get the official birth certificate. In other incidents, like for example, Egypt, he doesn't even need to go to the Civil Registration Authority. They will take the first birth certificate from the health institution. And then when he needs reissues of the birth certificate, then they go to the Civil Registration Authority. In some cases, the Civil Registration Authority will put officers into officials, into the maternity ward, into the maternity hospitals. So for example, in Sudan, they have 40 big maternity hospitals. So they have 40 registration officers, 24 hours, sitting in the hospitals to conduct the birth registrations, not only by notifications. So as soon as the delivery takes place, they will just take the paper notification from the ward and go to the lower floor where where the officer is sitting, and actually get the birth registered. And that part is electronic, and those civil registration officers are connected to the Central Civil Registration Authority. Same thing happens in mobile units, of course. They will go into villages and start with the mobile units that are connected to satellite or whatever. They print out birth registrations for children that were born and have not received birth certificates. But it works. And so the whole of the Gulf area now, the births are automatic, electronic, from the facilities into the Civil Registration Authority. The death as an event is exactly the same way. They had a few problems with the causes of death. So the Civil Registration Authority did not get the causes of death because of the selection of the underlying cause of death, which is much better. We prefer, as WHO, that the causes of death not be shared with the Civil Registration Authority, because they are confidential and kept within the Ministry of Health, unless it's, for example, like unnatural death, and they really require that to be shared. But otherwise, it works beautifully. From the community, what we are asking is that either they go to the nearest primary healthcare center and report the event, or a community leader, of course, whoever that community leader identified by the system, depending on the social capital on the ground, would complete a notification on the mobile phone, and that would go directly also to the Ministry of Health and the Civil Registration Authority. Then they can do some checking for duplicates, because that person in the community might be reporting the same event that took place in the health institution. So they have to do some validation and checking and reporting and so on. Over to you, Cha.
Thank you, Dr. Adsa. This is our last question for tonight's session. So, how have you been dealing with the data that you say are existing in paper in the ministries of health in various countries? And is it cost effective to try to digitize them?
Another very important question. This happens in many countries, and what they do is they ask WHO to help them with short-term contracts to do that. If they don't have the budget for it, so we in WHO, since this data is very important, and this is the backlog that, and it provides essential, very important information for the COVID pandemic in some countries which started reporting COVID death but did not have historical data, no historical data. So how are we going to even assess excess mortality? Because they have nothing to compare with. But countries that do have paper records and they want us to help them to finish up the backlog, I think we can help them do that. We just get some data entry people and we do it in a systematic, standardized way so that they are all entered in the same way and we solve the problems and we get very important information. So we can help you do that as well. But we, of course, find it not only cost effective, but it is very important. But not digitize them means scan them. No, not scan them. Actually do the data entry. If you just scan them, you have nothing. You have no data. You have to actually start developing a platform or use your existing platform and start extracting the information from the paper records and do enter them on the platform that you are currently using. Over to you, Cha.
Great. Thank you very much, Dr. Adsa, for sharing your time and expertise with the AeHIN community. So before we finally close, may we now call on our chair, Dr. Bunchai.
Thank you very much, Dr. Asa. We have learned a lot on the CRVS, and we will sure will use all the tools and will be collaborate and very close contact with the WHO headquarters and regional on this CRVS challenge in our regions. Thank you very much for every
Thank you, Dr.
audience.
Bunchai.
Yeah,
Thank you very much. And greetings to all. Goodbye.
Bye.
Bye-bye.